Biomarkers in immunotherapy have a great promise for being able to separate out, potentially, those patients who are going to respond from those patients who do not respond or are unlikely to respond. And so our debate was really focused on two key areas of drug use of PD-1 and PD-L1 antagonists. The first group was non-small cell lung cancer patients and the degree of PD-L1 expression, as well as the clinical scenario in which those patients are treated, to really try to get to a place where can we really understand the ability of the biomarker to predict fully who will respond, and is it applicable? There's a lot of debating literature out there in terms of who may respond, who may not respond, and it's really dependent upon clinical scenario as well as the degree of expression of the marker. The second debate was the description of microsatellite instability and its application for specifically pembrolizumab, but also other drugs that are PD-1 antagonists. And microsatellite instability really reflects the ability of the cancer to repair itself after it's been damaged by something. And frequently what's seen in colorectal cancer, and to a tune of about 15% or so, are patients who have mismatched DNA repair, meaning that they don't have the ability to repair themselves very well. Functionally, it kind of means that the cancer is very much not like the host, and so the immune system has an easy time understanding it and seeing it, and therefore going after it with these mismatched patients. A lot of the examples, particularly for the PD-L1 expression question, were in other cancers, including melanoma and bladder cancer. And what was done was a presentation of data looking at retrospective analyses of PD-L1 expression in those patient populations, which is interesting, but really should be thought of more as, in my mind, hypothesis driving, meaning that future trials should ask these questions prospectively rather than simply look to see retrospectively who responded and who didn't, because that certainly has some statistical flaws as an approach. All these drugs, for the most part, with the exception of specific lung cancer patients, have been approved with the absence of needing PD-L1 staining as part of a measure of whether or not patients will respond. And that's across many different cancers: head and neck cancer, bladder cancer, melanoma, Hodgkin lymphoma, renal cell cancer, as all examples where PD-L1 expression wasn't required for patients to receive these therapies in trials.